Good morning, everyone. Welcome to this session, Debunking the Myths in Pulmonary Hypertension. This is a new session for the PHA, so we're going to see how this goes. My name is Jeff Sager. I'm a pulmonary critical care physician from Santa Barbara, California, and I have an esteemed panel here of very smart individuals that hopefully will be able to answer as many of the questions that you can come up with. This session is being recorded, so if you're going to ask a question, if it's possible to use that microphone over there so that it can be documented. So to begin with, I'd like to introduce the panel so that everyone knows who we are. On my right is Abby Poms. Abby was the PH manager at a very small little community place called Duke University for 25 years. And Abby recently is taken on doing clinical trials with a company called E Squared. On my left is Dave Badesch from the University of Colorado. And on my further left is Darren Teichman from the University of Pennsylvania. So with that being said, I will start with the first question that was proposed, and then we can get going. The first question was, if you don't like what your doctor says, the doctor is wrong. I'm not sure who put that question in, but maybe my wife did. But yeah, that's an interesting question. We'll leave that one for the end. Okay, we'll come back to that. All right. So, does anyone have any questions to begin with first, and then we can answer? Does anyone want to start?
So, as professionals within the PH realm, I read that first question inside our notes. It said, because I can't lose weight because I can't exercise. Right now, I'm in pulmonary rehab, and asking the myth of not being able to ask your doctors to be part of your advocacy for more activity and stuff, is that a myth or is that a fact? I mean, is that something that, as PH doctors, do you understand what I'm asking about activity levels and exercise?
Okay. Who was? I did. Okay, sure. Darren will help.
So that's a very important question, and the truth is that doctors were wrong for a long time. We, as a group, were taught many years ago that, we didn't know much about PH at all. Because there was nothing known and we had no therapies, and so we probably perpetuated this 20, 30 years ago, and many of us haven't learned since then to tell our patients, and said, you've got a dangerous disease, you need to sit on the couch. And all we did by telling you that was take a bad disease and add another bad disease to it, and that's the disease of being deconditioned, so that your muscles are just out of shape. And so that's not helping you. So it is a myth that because you have pulmonary hypertension, you cannot exercise, it's not safe. That's not true. Now, of course, there are limits for some people, and everyone is different in terms of what their limitation is. But it is good, I think, as a general statement, it's good for everyone to find some exercise regimen, some activity level that they can safely do. The hard part, and you mentioned rehab, the hard part is finding what is that exercise regimen. Because let's say you've become deconditioned, and I could, because of this myth, and you haven't done any activity, and we could magically snap our fingers and your pulmonary hypertension was a bad dream and it's gone. You'd still be out of breath when you went to get up off the couch now after so many years of being just flipping the television channels. So you'd be out of breath, but that exercise would be a healthy out of breath, an invigorating being out of breath. How do you figure that out? How can you tell what's dangerous and what's a healthy, invigorating being out of breath because you're exercising? A rehab program, which is what I thought you asked about, is very helpful that way, because you start off in a safe situation where you can learn, yeah, this is me, my oxygen level's okay, my blood pressure's okay, I've got an expert here, this is my body getting back in shape, and it feels good. But you will have limitations. We all have limitations. So I think that the message is, to your question, you should talk to your doctors. If your doctor is telling you, no, you can't perform any exercise, there's probably something wrong there, honestly. But I doubt that's what you're going to hear anymore. I hope not. And almost everyone can find some kind of exercise. They might not be able to use their lower extremities. It might need to be their upper extremities. But there's a regimen for everybody. And beyond your pulmonary hypertension, it's good for you. You don't have to have, we know that exercise is, the last thing we need with PH is to get another problem in addition to deconditioning. It's good for high blood pressure out here. It's good for your metabolic health. It's good to help lose weight. But although that might not be a realistic goal, it's nonetheless good for you.
I just want to add to that and Darren touched on this, but it's really critical to at least when you're first embarking on exercise and you've been deconditioned for a long time, to be in a medically supervised program. And if there isn't one in your community, there's usually a YMCA or some kind of local facility where at least you can have some sort of supervision. You can also purchase a little oximeter or something to make sure you check your oxygen levels, or even have your physicians or your nurses try to help you form a regimen for yourself that's safe even at home. But don't go at it alone.
Hi, I have a pediatric patient, and the stat we're all given online is life expectancy is 2.5 years once you're diagnosed. That's obviously not super accurate. Once it's diagnosed, you're on medication, the child's doing well. What, in your experience, is now a more probable life expectancy for a PH patient as opposed to the 2.5 years?
So I don't think it's appropriate to give someone an anticipated life expectancy. I don't think we can predict that. It changes over time, and it's a highly individualized situation. So I'm very reluctant to do that in the clinic. And the 2.5 years business, that's older than I am. Yeah, that's really old. But that's based on data from the 1980s in an NIH registry that predated any of the currently available therapies. So it's completely out of date. It's a mean or average figure that's not appropriate to use anymore. And I don't like to offer a general anticipated prognosis anyway. I don't even try to individualize it very much, because I find if you do that, you're often wrong, and wrong on the good end, meaning that patients tend to do much better than we expect because therapies are evolving over time. So.
I'm a graduate of Duke University rehab program. I have two daughters who are graduates of the university itself. What does it mean if your oxygen levels rise with exercise, as opposed to what we heard this morning at breakfast, lowers with exercise? And secondly, a follow-up question is, are the direct measurements of pulmonary pressure by catheterization ever wrong?
Well, I'll answer the second question first, and I'll leave the first one to you guys. Are the right heart catheterization measurements ever wrong? It's a really good question, because like with any test that we do, there are limitations and accuracies that need to be taken into account. So if you're doing a right heart cath on an individual, where it can be wrong potentially is just the technique that it's being done. So there are certain things that are done during the catheterization that need to be ensured. You have to make sure that the transducer, when we do the pressure measurements, are the correct level. You have to make sure the patient is correctly positioned. The technical aspects to it is how you interpret some of the data that is generated at the time of the catheterization. In the old days, what we used to do was we would have a pressure measurement, and we would manually look at where the pressure should be measured, for example, at the end of your breath. The newer technologies with the machines are all computerized and digital, and it's a good and a bad thing. The bad thing about it is that it often uses averages. So if you're not carefully looking at the tracing, some of the measurements can be measured when you've taken a deep breath, and that could artificially make that measurement high when it isn't necessarily the case. So it's important when you're doing, like with any test, not just with right heart catheterization, that it's done by someone with experience, specifically if you're dealing with pulmonary hypertension, somebody who has experience with doing cardiac catheterizations, because there are certain nuances that are specific to our group of patients. The same thing about using oxygen at the time of the right heart catheterization. If somebody has very low levels of oxygen and they're not on the oxygen and you're doing the catheterization, the pressures may be higher than what they would be if they were on oxygen. So those are the kind of issues you have to look for. The first question about exercise.
Your saturations are better when you exercise, is that right? Keep on exercising. That's great. No, seriously, sometimes people get kind of better lung expansion and whatnot when you're exercising and things, so it's not entirely surprising, and that's a good thing. Yeah, it's wonderful.
I have a question. Different doctors seem to have different policies on this. When my mother originally was diagnosed, they were doing multiple heart caths, just consistently. When she's changed to another facility, another doctor, they are not repeating them that. How often should the right heart cath be repeated?
So that's a great question, and it does vary a lot, and I think that we probably vary around this table, although maybe a little less because we're, many of us are from a lung specialty or pulmonologists. It often varies according to whether someone's a pulmonologist or a cardiologist. This might be a frustrating answer in that there is no one right answer. It's important for sure that a right heart catheterization be performed to get the diagnosis and help direct you to the right therapy. But thereafter, there are absolutely outstanding colleagues of ours who will regularly do a heart catheterization on a scheduled basis, be it annually or at some other frequency. Then there are those of us who do it more when we feel we're confused, we don't really know what's going on. And as a research community, we have not figured out whether one way is better than another. So that's frustrating for you as a patient. I think what's the honest answer is that it's, if you're at an expert center and that's what your physician feels she needs to help guide your care, be it a heart catheterization on an annual basis or other people doing it as needed, I think that it can be appropriate either way. There's not one single answer, unfortunately.
I'll just add to that, to what Darren said. There are certain things that we know when it's the appropriate time for the right heart cath. So, as Darren said correctly, at the time before you start any therapies, you really should have a cath before any therapies are started. We also know that on certain patients who a small percentage of those that are what we call acute responders, we would use certain medicines on those specific patients. And the important thing about that is that you have to make sure that they maintain their acute response. So those patients, the only way to know that is to repeat the right heart cath. So those are clearly times where if you are placed on medicines as an acute responder, you really should do a follow-up cath to make sure you maintain that. And then generally, as mentioned, is when things are not going well, it's often when patients will get another cath.
One other case now where patients are on infused therapies, pump-type therapies, and I know when people were going to get weaned off to more of the oral-type medications, sometimes we would do catheterizations to try to help guide those transitions from one therapy to another. I don't know if you guys do that as well.
We do tend to use the right heart catheterization prior to making significant changes in treatment. So.
But there are centers, terrific colleagues of ours who I would not for a moment say they're doing it incorrectly, who do feel that in their practice they want to see where your numbers are on a, let's say, annual basis. And as I said, if that's their style of practice and they're really expert, none of us, I think, would ever say that they're not doing it the right way.
I have a question. My portable concentrator is new, to me anyway, and I have been really fighting taking tanks places because they were just such a hassle to lift and fill and things. But I'm pretty active. I am finishing a degree to teach elementary school. And I'm hoping that being on oxygen might increase my energy level throughout the day, because by the time I get home in the afternoon or evening, even if I'm only there a couple hours, I am so wiped that I have to just lay down. My house is a mess. So is that true or not?
So I think the question is, will you have more energy if you use oxygen? So I think, we tell patients that that's an thing that we often hear from patients, and basically you either need oxygen or you don't. So there's lots of things that will make you feel tired, fatigued, and it's different for everybody. But I think that your healthcare providers need to carefully measure your oxygen levels at rest when you're exerting yourself, so trying to simulate what you do in your normal daily routine, and also at nighttime, because there's different times when you may need oxygen. But if the tests show you need it, then you need it. But just using it because you feel fatigued isn't really indicated, I think. Would you all agree with that?
Yeah, the analogy that we often use is that if your oxygen level is okay, if it's elevated or not elevated, if it's within the normal range, you can kind of think of it like a bucket of water. The bucket's full, adding more, there's nothing, you're not holding on to anything. You don't hold on or store up the oxygen. So absolutely, if the bucket is near empty, your oxygen level's low, we need to add. But if it's full, giving more water, giving more oxygen, and it isn't going to help. There's nothing more you can do with it. So.
Okay, we'll take one.
I always hear people saying, if you're a PH patient, don't bend at the waist. Should you or shouldn't you? It's kind of hard to do.
That's a great question.
Actually, it's a good question. We do advise our patients to be careful about bending over and standing back up, especially if you've got very severe disease. It can make you predisposed to syncope or passing out. And bending over and picking up a heavy object and standing back up may be particularly problematic. So that actually is probably a true myth, if you will.
I'm going to ask. I'm going to go over one of the questions that was asked earlier to us, and then we can keep going in a minute. The one question, and I'll give this to David, was oral prostacyclins are same efficacy as parenteral prostacyclins?
That's a great question. It's we've always wanted a more convenient way to deliver prostacyclin therapy than intravenously, and been a lot of research around how to do that into subcutaneous delivery modes, inhaled, oral, implantable pump, and those things, there have been advances over the years that have perhaps simplified it some, but this question about which one is most effective, or are they all equally effective, I've got to tell you, my personal response to that is it can't really be answered unless you do what's called a head-to-head study, and there have been none of those. So we can't really say that one mode is more effective than another. My personal bias is that for patients with the most severe disease, the intravenous prostacyclin therapies are the most effective, or the ones that go to treatments. But that's my opinion. It's not based on head-to-head studies. I think most people in the field would agree with that. The oral drugs coming along, oral treprostinil has been shown to be a benefit in a monotherapy situation, but it's still a little controversial how well it can be combined with other therapies, whether it has additional benefit. And then selexipag, though, a prostacyclin receptor agonist, another oral therapy, appears as though it does confer additional benefit over and above background therapies. So we're gaining more and more evidence around these modes of delivery of prostacyclin therapies that may be simpler.
Yeah, I would just add to that. I think I would be very careful about somebody saying that, for instance, I've been on a inhaled prostacyclin therapy, and so not doing well, there's nothing else out there for me. I think almost all of us would agree, if you're not responding to one type of prostacyclin therapy, be it a pill type form or an inhaled type form, I think we would all agree that we would want to make sure that we get you onto some type of pump therapy, because it has been shown to be effective. There has been shown to be a benefit, what we call a mortality benefit. So we do have a lot more information about those therapies. They've been around a lot longer, and I do think we tend to think they're more potent. So because you fail one prostacyclin therapy or maybe aren't doing well, I think it's really important that you talk with your physician about stepping up to another prostacyclin therapy.
Good morning. I'm newly diagnosed with PH, and I'm taking oral medications since it is a progressive disease. Can a patient continue to thrive on oral medication, or will it eventually lead to oxygen or a central line put in for us?
So another unfortunate, not satisfying answer that we don't know. Many people, we all have patients who have done well on oral therapies for 10, 15, even more than, well, not more than that at this point, but just because of how long they've been around. But we've had patients who do well and continue to do well, and there's no reason to believe they won't stay that way. Unfortunately, there are people with PAH who will do well or not even initially do well at all with the oral therapy, and their disease will progress and they need to go on to one of these other forms of therapy, including that pump into a vein. We don't have a good way up front when you first start for us to predict what's going to happen in your future.
And this is the reason why it's so imperative that you follow up closely with your physicians. You know, one of the things I always say to the patients newly diagnosed and my established patients is that we don't know what happens from month to month, and the reason we do additional testing, why we repeat your oxygen assessments and sometimes repeat the right heart catheterizations and the echocardiograms, is to try and understand what is happening with the progress of your condition.
So if you were diagnosed in 2008 and then you said something about 15 years, so if I add like 6 more years from now, are you saying you don't have patients that haven't been diagnosed longer than 15 years ago? That's not what you're saying, right?
No, that was with respect to the availability of oral therapies, I believe.
Yeah, it's just that's not true. That absolutely not. Please do not think that we just made it, or I just made a statement saying that, well, you've got this clock of 15 years on these drugs. No, that's just an issue of a round figure of about when we started having some of the current drugs that we're using that many of you might be on. That's just how long we've had them. There's nothing to indicate, though, for example, I don't know about the rest of the people on the panel, for people who've had patients on some of these drugs for 10 or more years, that are doing well, reasons why we would expect that won't continue.
All right, I'll ask Abby a question here. This also came through, and that is, medications are bad and natural remedies are better.
Oh, one of my favorites. I think we've all experienced this frequently in clinic, where patients will ask about using natural remedies, and I think that the short answer is there are a lot of products out there, and they can make a lot of claims to do a lot of different things, but in reality they're not studied scientifically. Like the medications that many of you are on go through very rigorous clinical research trials. And at the outset, we're tasked with answering specific questions about what these medications do, and very carefully follow the safety profile to make sure that there can be a really great medicine and it does what you want it to do, but the safety profile is so unacceptable that medication will never get approved by the Food and Drug Administration. So while there are a lot of claims out there about natural remedies, and I'm not saying that they're all bad, But you absolutely need to speak with your medical team about something before you take it. And I think a good example is herbs. We all think of herbs as we grow them in pots in our gardens, and they're wonderful things, and we put them on everything. But particularly if you have a heart condition, there's many herbs that actually can make you worse and can interact with a lot of the medications that you're on. So, natural sounds great. We'd like to all be natural in everything that we do. But there just isn't a lot of information to substantiate the claims that are out there. So you have to be very, very careful what you're doing. There's also been some natural remedies that have actually caused disease, and I think even caused pulmonary hypertension in some cases. I think there was an oil, right, a grapeseed oil.
Yeah, and the classic example is L-tryptophan.
Yep.
Tryptophan's a naturally occurring amino acid, and it was sold as a sleep aid years ago, and there was an impurity in the preparation that caused something called the eosinophilic myalgia syndrome. Part of that syndrome was pulmonary hypertension.
So we've seen it actually cause pulmonary hypertension. So you just have to be very, very careful. I'm not saying they're all bad. Certainly some that can be taken safely, but you want to make sure you discuss this thoroughly with your healthcare providers.
And to add to that, for last year, the European Society listed, for example, St. John's wort as a concerning medicine, as a possible association. That's a common one that's used. It also interacts with certain of the medications we use. So just be mindful. There are obviously medications that patients use, herbals that we use routinely as a natural remedy. For example, patients who are often on prostacyclins, who have problems with diarrhea, will often use probiotics in those situations and as natural things to help with that. So it's a discussion that needs to happen between you and your healthcare provider.
Hello. First of all, thank you so much for answering all these questions. This is wonderful. But I was wondering if you could please speak on general anesthesia and pulmonary hypertension. I recently had to have emergency surgery, and it was just
Yeah, so we try to, first I think we want to avoid non-essential surgeries. It puts patients at unnecessary risk. And then we try, if it's absolutely necessary that you have surgery, try to mitigate the risk to the extent possible. And there are a number of ways to do that. We try to avoid general anesthesia if it's possible. A local or regional anesthetic may be safer. The other precautions that we take with surgery, our patients tend to be prone to what are known as vagal events, where the heart rate slows down and the blood pressure falls, and vagal events can be precipitated by pain or nausea, things that are typically associated with surgery. So we try to avoid those things. During surgery and following surgery, when you're receiving pain medicines and things, it's important to avoid hypoxemia, low oxygen concentrations, and hypercarbia, which is high carbon dioxide concentrations due to not breathing enough. Other surgical kinds of precautions that we recommend, one of the major risks associated with surgery in everybody is deep venous thrombosis, blood clots in the legs that pass to the lungs, called pulmonary embolism. We try to prevent that in everyone. In patients with pulmonary hypertension, that's particularly important because you may not tolerate a pulmonary embolism as well as someone else. Those are the sorts of precautions. We generally recommend that procedures are done in a very well monitored situation. So anything more than a very minor procedure, I tend not to like to have done in an outpatient surgical center. I think they ought to be done in a more heavily monitored environment in a hospital where emergency services are available, and even pulmonary hypertension expertise if it's a major procedure. So, yeah.
And I'll just add that even in very stable patients, it doesn't matter if you're a stable patient, there's enough that happens throughout anesthesia and in an operating room that can make you unstable very quickly. I see Betsy here. She just underwent very stable patient for a long time and just had a very emergent situation, and that they wanted to operate on her at the local hospital, and luckily she was smart enough to know that she needed to get to her PH center to get that surgery done.
One other point to just add to the discussion about surgery is if it does have to happen, as Dave said, we prefer to have it in a planned setting where you're at a place that has the expertise. In case it's forgotten, we have to plan for when you're recovering in the hospital. And so it's a good idea to ask which of your medicines you should be bringing with you, not just the list of medicines, because many of your hospitals will not have the oral therapies that we're using, your inhaled therapies, and they may need you to have your own stock there. You need to give it to the nurses to then provide it to you, but it's nice to have planned that so that we don't wake up the next day and your family's running home to try to get your bottle of this medicine that's frankly too expensive for the hospital to have carried itself. So it's good to just plan that ahead and talk to your doctors.
I think to add to that, and there's not much more to add, you guys have covered it pretty well, is that if you're needing to have the surgery, it's important for you to meet the anesthesiologist and make sure that there's a dialogue between the anesthesiologist and your pulmonary hypertension specialist, because I find that is often where there's a breakdown, because the anesthesiologists are just whoever's on call that that hour that you're having the surgery, and that's where the problems come, where there's lack of communication. So I think you should try and insist that you at least meet the anesthesiologist and have them have a dialogue with your PH doctor.
There's actually one more point that I remember came up with one of my patients, and hopefully this will never happen to any of you, but there are times when it is truly an emergency situation and you need emergent surgery, a ruptured appendix or something like this. In those situations, because you're knowledgeable PH patients, you may be worried and say, I cannot go to the operating room, and you're at some hospital that you're not familiar with and they can't transport you. It's important that they talk to your doctors, but sometimes there are situations where it's an emergency and not doing the surgery is more dangerous for you than waiting around to try to do things in an elective fashion. So sometimes we don't have the luxury to do everything that we were saying, and that's just an unfortunate reality. Hopefully it'll never happen to you, but it's important to realize that sometimes not doing something is more dangerous than trying to do it the perfect way.
And just one last point about surgery. So if you're on pill form medication or inhaled form medication that you may not be able to take because, number one, you're too sick or because you're undergoing surgery, that's really critical. Your body relies on those medications, and so you really need to have a discussion about how will I get my treatment during this course of surgery and after surgery. It may be that you have to be on an IV medication for a period of time or something, but those are really critical things to think about. You can't be off of your pulmonary hypertension medications for an extended period of time.
Got a two-part question, kind of moving back towards the medicine versus natural, and it's health and wellness. One is any issues about organic versus, the normal grocery store off-the-shelf foodstuffs, any betterment in the health or the interactions with the various medications if you stick yourself to just going, I'm going fully organic versus picking a box of rice-a-roni off the shelf. And number two is there's, weight is a big issue for a lot of folks.
No, I would go over rice-a-roni. I'd go organic any day. Yeah.
But there's a heck of a lot of diet plans and weight plans out there that use the magic powders and things like that. Yeah. Are there any diet plans out there that the PH doctor community says, hey, if you really are trying to lose weight and you're on a medication, here's the best route we've found?
I don't know. I'd like to hear from my colleagues, but I kind of always have recommended the tried and true Weight Watcher diet, or you follow the American Heart Association diet. Obviously you want to think about things about sodium intake and trans fats and things like that, but I think for me organic foods just imply that they haven't been there's no pesticides or chemicals or things, so I don't think eating organic apples versus non-organic apples is really going to be hugely different to you. So I guess I'd say I would always err on the side of something being organically grown is probably better for any of us. But all of these fad diets or, taking supplements, I think goes back to that whole question of, are they safe? Have they been studied? And I think if you just stick to some, regular routine type of diets that just are all around good nutritional, and you get some protein and some vegetables and some fruits and that sort of thing, I think is what I've always recommended to patients. I don't know what you guys do.
Same.
Yeah, I think that the difficulties with patients with pulmonary hypertension is they often have the lack of the ability to exercise and burn the calories. I think, as you know, weight loss is a component of what you put in and what you can burn out. So the problem with pH is that it limits sometimes your ability to walk or exercise. So controlling what you take in is paramount, because you can't just go out and burn it off.
My question is, when I was first diagnosed, I was in stage 4 heart failure. I'm now on a triple therapy, and as of Monday, I'm out of heart failure. My question is, if you're on a triple therapy and improving, is it realistic to think that you can reduce dosage or therapy over time and possibly improve or stay stable?
So that's a great question. The question is, once you are controlled, can you either come down on the therapy or stop the therapy? Unfortunately, all the therapies that we currently have to date really control this disease. They don't cure this disease. So the analogy I use is the same as regular systemic blood pressure. When somebody has high blood pressure and they take a blood pressure medicine, the blood pressure comes down. You control that blood pressure medicine by staying on it. You don't come off the blood pressure medicine, right? Same kind of a concept with pulmonary hypertension. The issue is that often with time you can start to adjust doses so that you are minimizing side effects. But generally speaking, once you're on them, we don't usually take patients off therapies, because this medicines that we have current to date don't fundamentally cure this disease.
Can you answer the question that's on the handout? Transplant should be only discussed during the final stages of the disease.
The timing of lung transplantation or heart-lung transplantation is one of the more difficult challenges I think that we face. I can tell you back early in the field, we addressed lung transplantation almost immediately when we saw a patient because we thought that medical therapies were just temporizing, trying to get someone to transplant. But now, as we've discussed a few times this morning, we've got patients that have been on medical therapy for 20 plus years and things. It's, really is amazing. We try to delay transplantation as long as is reasonably possible. And where it becomes challenging is when the risk of transplantation begins to go up because the patient's health is declining, to such an extent it puts them at operative or healing risk. So I try not to wait to that point to begin to discuss transplantation. I think transplantation needs to be discussed when you're having issues controlling the disease with medical therapy. So recurrent episodes of right heart failure, for example, or fluid retention, recurrent episodes would tend to precipitate that discussion around lung transplantation. So, yeah.
And I think we always talk to our patients about this window of opportunity. So with lung transplantation, as Dave said, if you're still in class 3 or 4, later class 3 or class 4, and you're on maximal medical therapy, this can be a very good option for you. But if we wait too long and send you to our transplant colleagues in a state such that you're so decompensated, they actually might not even consider listing you for transplant. So we want to make sure, we always would tell patients, we want to just send you and kind of get you in their brain so they know who you are. That doesn't mean they're going to transplant you right away. They may do their workup and decide that, you're not ready for transplant, but we'll see you every 3 to 6 months. And your PH doctor will send you sooner than that if they think that things are changing. But it's definitely good to have that in the back of your mind, and it's critical that you not wait too long. There's also a big process to go through. Sometimes patients have to raise money for transplant, depending on your insurance situation, and so you need time to get ready for all of that, and so you don't want to wait till the last minute.
a testament to the treatments that we've had for pulmonary hypertension are the fact that back in the 1990s, about 10% of lung transplants done in the United States were done for pulmonary hypertension. And in the 2000 era onwards, probably less than 3%. In fact, it is less than 3% are done for lung PH patients are transplanted. So the treatments have held patients away, from transplant. The downside to that is those that are getting transplanted are obviously much sicker because they're the patients who are failing the therapies. So it's an important thing to have a discussion with your physician about that.
I have two questions. The first one might sound stupid, but I will ask it anyway.
Nope.
Can this disease disappear the same way that it appeared? Have you, in your experience, seen somebody who get healed with a therapy or without? And my second question is, I heard that if you switch therapies, especially my son has IV therapy, and we are thinking of switching to oral. I heard that if you switch to oral, if it doesn't work, you're not going to go back to IV therapy. Oh, is that true, or why is it true?
So to your first question, can the disease disappear? Unfortunately, no, not as far as we've ever seen. To your question of if somebody goes from intravenous and then switched to drugs by mouth, and the drugs by mouth don't work, they can't go back. As a general statement, there's no such rule. There might be reasons why the doctors said for social reasons, for example, that this isn't safe to give this patient intravenous medicine. It's not working out, so it might just be safer to use pills by mouth. If those safety issues haven't gotten resolved, the doctors may very well say it's still not safe to go back to the IV. But as a rule, no, I don't think that that's something that we would say is a rule that we go by.
I think in transitioning patients from one therapy to another, we're always clear because, as Dave was saying earlier, we don't have head-to-head comparison trials. We've always talked to patients and said, you're doing well and we'll support you in doing this transition. We think it's a good idea and safe to do, but we cannot guarantee you, if it doesn't work, that when you go back on your intravenous therapy, for instance, that we can get you back to where you were before you transitioned off. Most times we can, but we just can't make those kinds of guarantees, and I'm not sure if that's what they were sort of suggesting.
I have a question, and I'd like to also make a statement. My question is there an age cutoff for transplants? Say 68, 70. I've heard that once you get to a certain age, doctors just say it's too late or you're too old.
That is true. Most programs around the country have certain age cutoffs, and it's very center dependent. So there are some centers that who potentially have higher volumes have a more of a leniency with the age. The reason that there is a age cutoffs is not because for any other reason other than that we've looked at patients who are older who get lung transplant have much worse overall survival than those that are younger. And why? Because the medicines are toxic. The kidneys take a hit when you're getting the transplant in terms of the immune suppression. So the older one gets, the more challenging and tougher the transplant is to take on the body. So it is center dependent, and some centers have lower cutoffs than others. So you should really find out from your local transplant center what the age cutoffs are.
Good morning. My question is, I've heard a lot of stories about patients who get lung transplants and who are on the wait list for lung transplants, but I've been told that in order to make things right, one should get lungs and a heart.
So it's for most patients with pulmonary hypertension, a lung transplant is adequate. And there's been a debate over the years, should it be single lung versus double lung? Patients with severe pulmonary hypertension, I think, tend to do better with a bilateral lung transplant than with a single one. And the explanation for that's a bit complicated for this session, I think. But the heart-lung transplant is usually only necessary in a couple of situations. If somebody has underlying congenital heart disease, a hole in the heart that can't be corrected at the time of transplant, then that patient might need a heart-lung. If they have some other problem with the heart, like coronary artery disease or something like that, again, that can't be corrected at the time of transplant, they might get a heart-lung. And then finally, there are very rare patients where the right ventricle, the right side of the heart, has failed to the extent that it just can't come back following transplant, but that's extraordinarily rare. Usually the function of the right side of the heart recovers quite well following transplant.
And it's also much more difficult to get a heart-lung transplant, and surgically it may even be more difficult to do a heart-lung transplant. So, I mean, at all costs, if we can get away with a double lung transplant, that's the choice.
Better to have your own heart.
I was supposed to get a transplant, but then they said that if I got a transplant, I'll be trading one disease for another. So as long as my body works good with the medication, that I shouldn't, because lungs only last 2 years. Is that true?
What?
Lungs only last 2 years.
Okay. So the answer, a few points on that. Number one, yes, you are trading some chronic disease with another, because the medicines and the ability to maintain the lung transplant does require ongoing medicines every day and monitoring of side effects, including all the immune suppression, the risk for infection. It is true to a degree that pulmonary lung transplant does not have as long survival as, for example, a pure heart transplant or a kidney transplant. The average survival statistics that we have to date are that about 60% of people are alive at 5 years, and about 30 to 40% are alive at 10 years. Now, that doesn't mean that you only have 2 years, like you're saying. We've had many patients that live 10, 15 years with a lung transplant and beyond. So the very first question we had about survival, somebody had asked us in the very beginning of the session. Generally, as physicians in this field, when we're dealing with chronic illness, we don't give a prognostic time limit or a time stop on anything, because it's very patient dependent. It depends on a lot of other conditions that you have. It depends on many other factors. So it's very hard to give a prediction of that. And so patients, when they do get a lung transplant, can do very well for a long period of time.
It seems in the future we may be able to use our own stem cells to grow organs for transplant, and use your own. Will that never be an option for PH patients, or will the risk of getting another set of PH lungs eliminate that possibility for those patients?
I think stem cell transplantation for pulmonary hypertension is not yet a reality, but it's something that might be a possibility in the future. And I've learned a long time ago, never say never. I think one of the fun things about this field is actually how rapid medical advances have occurred over time. I mean, it's pretty incredible to go from 0 therapies to 14 over a period of 20 years or so. And I think we can't really predict, what might be possible in 10 or 15 years. I'm excited to see that, someday, to kind of see how we're treating the disease a couple of decades down the road. Martin Wilkins, a scientist from the UK, gave a very nice talk yesterday afternoon about sort of the future of therapies and what might be possible and things. I'm excited about that. I think the future's bright. So.
Yeah, I agree completely. We're learning more and more, and there are experiments about stem cells and their ability to help with, or one day help with any of a number of lung disease. What is a little dangerous today, unfortunately, and I don't know if it's still going on, but there are some, I'll just call them charlatans, thieves, who are, quite frankly, looking to take advantage of desperate people who are looking for any kind of hope. And they're offering, quote, stem cell therapy, sometimes outside of the United States. And people go, they spend a lot of money, and when we as a community have pressed those individuals for, show us your information, show us the data that you're actually helping people, the data really aren't there. And so it's really sad that there are some individuals who are taking advantage of desperate people who will grasp at anything. And so we need to be careful. And so and that's true not just for stem cell, but that happens to be an area where we know it has gone on, and people spend a lot of money for something that isn't true. But anything that sounds too good to be true in general, you really want to be talking to your doctor about it.
Okay, last question. Yeah.
This might be a basic question, but I'm having a hard time grasping at it. The pro-BNP blood levels that we check for the heart function, how do you gauge when there's a true problem? We've been in the thousands and there seems to be no concern. But there's other friends that have been in the hundreds, and the doctor's very alert and checking a little bit more acutely for the heart function test.
So there are two different kinds of BNP levels that we measure. There's a BNP level and an NT pro-BNP level, and the scales, the normal scales, are completely different. Okay, so you need to be careful about which one you're talking about. The BNP levels can be affected by many different things. One of the more prominent things being renal function. If you have kidney dysfunction, the BNP levels are sort of less reliable. And then the final thing, I think, is that the BNP levels shouldn't be taken out of the context of the entire clinical picture, and that's probably the most important thing. If we see a rising BNP level and a decline in exercise tolerance and echocardiographic evidence of right ventricular failure all at the same time, we most definitely pay attention to that. You know, if you see an isolated bump in a BNP level, it might make us take a further look at things, but we might not act on it by itself.